Good day, everyone. This is Dixie Luis E. Sanchez from BSN3B, and this is Shared Psychotic Disorder for NCM 76, care of clients with maladaptive patterns of behavior, acute and chronic. For the objectives of the discussion, we have definition, 4 types of shared psychotic disorders, characteristics, and nursing management. To start, shared psychotic disorder is also known as folie à deux, which translates to madness for two. Shared psychotic disorder is a rare condition that involves two people in a close relationship that shares the same delusion, influenced by the one that already has a psychotic disorder with prominent delusions. In a two-person scenario, the one who influences the other is called a primary partner or inducer, while the one who receives the delusional ideas or is influenced by psychotic mannerisms is called secondary partner. This disorder does not necessarily equate to primary partner as someone older or a man for that matter. Rather, in some cases, the younger person tend to influence the other person to have more delusions, signaling that shared psychotic disorder occur not by age or by gender, but by the duration of the relationship shared and how isolated they are from their reality to end up sharing the same disorder. There are 4 types of shared psychotic disorder, namely imposed psychosis, communicated psychosis, simultaneous psychosis, and induced psychosis. The first one is imposed psychosis. The delusions of the primary partner is transferred to the secondary one with no history of psychosis during the intimate relationship. The delusions will eventually disappear if the two are separated. As the intimate relationship comes to a halt, so does the transference of delusional ideas from the primary partner to the secondary partner, as the other was only affected by the delusions through the long relationship and attachment. Delusions then disappear if separation becomes permanent. The second one is communicated psychosis. The delusions of the primary partner is being resisted by the secondary one during the ordeal, but gives away after some time. The delusions remain even after the two are separated. Unlike imposed psychosis, communicated psychosis victims or the second partner adopts a new personality combining both his or her delusional ideas and aligning it with his or her personality as a result of a constant resistance established earlier. Third, simultaneous psychosis. Both partners share the delusion simultaneously, usually after a triggering event that leads them to develop the condition. This type is commonly associated with genetic risk factors and occurs more often with siblings. In some cases, simultaneous psychosis presents that the primary partner and secondary partner both develop delusional ideas after circumstance that introduces psychosis after problem or a scenario. Lastly, induced psychosis. Both partners are already with psychotic condition before in contact with each other. Then the primary partner introduces new delusional triggers to the secondary partner, adding to the already existing delusion of the latter. The secondary partner uses the delusional ideas to incorporate the procedures and delusional acts. Lastly, in all of the types of the shared psychotic disorder, the secondary partner is usually seen with comorbidities and cognitive and mental impairment as risks for increasing the rise to develop this condition. Now for the characteristics of shared psychotic disorder. The characteristics are commonly seen with shared psychotic disorder. It is also worth noting that these can easily vary as a person can undergo varying degrees of the condition. Albeit the severe cases, people who are further diagnosed with shared psychotic disorder appear to be normal and presentable until delusions take over and they act out differently. So, first, defensive behavior is seen with once delusions are tested. Next, present hallucinations that varies accordingly. This varies accordingly with the four types of psychotic disorders, has no insight into their mental illness. They are usually oriented with time, place, and person, unless delusions become overpowering. And lastly, thought process on beliefs surrounding religion and society appears to differ from common norms. For the nursing management, first is to attend to the patient feeding and medication intake as patients may pose risk for having food poisoning delirium. It's important to monitor the patient's intake when one experiences psychotic episodes to avoid sudden thought of the drug hurting them or the treatment doing nothing for them. Additionally, allow patients to feel validated in their fears while keeping them informed. Second, display acceptance to patients' experiences while providing sense of reality. When patients lose the sense of reality because of the disorder, they will recognize voices that they've assumed to be real. Handling hallucinations through careful acceptance of its existence in psychotic disorders will allow one to effectively explain that they are not really there but only part of the disease. Third, assist patients in severe cases that require hospitalization. When cases need hospitalization, constant monitoring and education on the importance of separation techniques is significant in allowing one partner to develop boundaries healthier than those in the shared psychotic disorder. Fourth, after treatment, provide psychoeducation concerning the causes of the disorder, symptoms, and coping strategies. That would be all for shared psychotic disorder. For more inquiries and questions, you can refer to these references and study well on the shared psychotic disorder in order for you to learn more about the disease. That would be all for my report. Thank you so much for listening. Good day.